So vascular access is very important, be it PCI, be it any kind of structural intervention, because half of your complications actually occur in this. So how many of you routinely use ultrasound access for the femoral intervention? Can we have a quick raise in hands? Routinely for PCI also? Not much. If you want to do tabbing, would you like to do an ultrasound access? Almost everyone. Okay. So basically, it all started with Soames trying via brachial cut down, and then we have come a long way from that, and now we are using this modified cell linear technique using ultrasound guided and micropuncture kits and all. So the radial complications, the radial first approach nowadays has again brought back the femoral complications, which are actually in the decline, because most of the operators now are slowly, the younger generation which is being trained are losing those femoral skills. So there are various factors, but operator technique actually quadruples the complications. So we have to be very careful from our perspective. So what is the goal of a good femoral puncture? So it should be above the femoral head. So if everything fails also, you can compress the artery against the femoral head. Second, it should be within the confines of the common femoral artery. So the upper border being the lowest portion of the inferior epigastric artery, where it loops around the inguinal ligament, and the lowest should be at the bifurcation, above the bifurcation. So third, it should be an anterior wall puncture, no side stick or posterior wall stick, because it can cause the proplate to catch the posterior wall or the vascular closure device to malfunction. And ideally, it should be a 12 o'clock entry, central lumen entry, and preferably a disease-free segment, because when your puncture site is very close to the disease segment, be it a plaque or a calcific speck, the compliance of the vessel is not good. So it is prone for dissections when you pass your sheets. And obviously high punctures can lead to retroperitoneal bleeds or VCD, vascular closure device failures, and low punctures, they are notorious for pseudoaneurysm, AV fistula, bleeding and compartment syndrome. So one point what I want to make is, see, some people, if the superficial femoral artery size is adequate, but still common femoral artery is the place to puncture, because all the fascia of the abdominal muscles and sheath, they come down and form a femoral sheath, and it overlaps the common femoral artery. So that is why it is very less prone to pseudoaneurysms. So that femoral artery sheath doesn't extend onto the superficial femoral artery. That is the reason why if you have a low puncture and compression is also at fault, then you develop pseudoaneurysms. So what are the different methods? I'll quickly take you through. Palpatory method, age-old, fluoroscopic method, which most of us use on routine basis. Then some railroad technique and ultrasound guidance. So palpatory method, so the external landmarks, anterior superior iliac spine, pubic tubercle, that is palpate the inguinal ligament, 2 finger breadth below the inguinal ligament is the puncture site on the artery. So the skin puncture site should be even below, depending upon the fat in the groin. So the point of maximum impulse, you have to palpate 2 finger breadth below the inguinal ligament and then puncture at that site. So this is the palpatory method. So if you take the, just looking at the fluoroscopic, if you take the inguinal grease, the lower dotted line, so the inguinal grease, which is the lower dotted line, if you take it as a marker, then most of the times, 75% of the times, you will miss the common femoral artery. But if you take the inguinal ligament, then and point of maximum impulse, you are most likely to hit the correct part of the common femoral artery. So if you take a fluoroscopic guidance, then you divide the femoral head into 3 quadrants, upper, middle and lower third quadrant. So the middle quadrant is the most likely site, and in more than 90% of the cases, you can be assured that the bifurcation is below the lower point of the lower border of the femoral head. So in 90% of the cases, radiographically, you are sure that you are in the common femoral artery segment. But again, there are other techniques where you can go from the left side, from the right side, put a lima across, take an injection, and then put a wire across, and under this guidance you can do, or if you have a roadmap mask, where you can save the on the left hand corner you can save the mask image and then you can take a puncture. But none of this ensures that you are entering in the central lumen 12 o'clock entry. These are all helpful, but you are not 100% sure. So so this is the most common way of using ultrasound guided puncture. We all use a short axis view, where you can see here on the left hand side panel. So as you scroll cranially, you can see profunda femoris and superficial femoral artery combining to form a common femoral artery. Here you have an anterior block, so you can slightly go cranial and puncture. So this is the second needle tracking. You can see the needle, and this is the exact entry of the needle at 12 o'clock. But see, is there a dedicated way where you can do it properly? Yes, recently it has been published last year. So a 6-step approach, it is a little time taking, but if you practice it, then you will master it. Here you need both short axis as well as long axis skills of the ultrasound. So the step 1 is differentiate between common femoral artery and femoral vein. So this is, you have to use the short axis view. When you compress the femoral vein, because the pressure is low, it gets compressed. Whereas the artery doesn't compress and keeps pulsating. You can even put a color Doppler to know which one is the artery and which one is the vein. Artery has a pulsatile flow, vein has a continuous flow. So the first step is to identify common femoral artery and common femoral vein. So the second step is to identify the CFA boundaries. This is done in the long axis view. Here you can see, if you go cranially, you can actually see that yellow arrow indicating the dipping of the common femoral artery into the pelvis. So that means it has exited. It has exited the femoral triangle and it is entered into the pelvic cavity. So here you should not stick. And if you come caudally, you can see the bifurcation. So the second, identify the boundaries of the common femoral artery. The third step is femoral head visualization. Here you can see the red asterisk, that is the femoral head. And 4, identify the target area where you want to puncture in the femoral artery. So identify disease-free segment. So the red line, the asterisk is the femoral head, and the dot above is the place where you want to puncture. Then this is the most important step. So there are 2 techniques in that. People with, you look at the left hand side upper quadrant. So there is a lock on the ultrasound. So once you have identified the femoral head and the location where you want to puncture, the left hand ultrasound should not move. Okay, then you have to introduce the needle about an inch behind the ultrasound probe so as to the depth of the place where you want to puncture the artery. So the skin puncture is below the level at which you want to puncture the artery, but you are now able to see the screen on the left side below. So there is a very narrow path in which you have to tread your needle. So, and most important thing here is the ultrasound beam should not be angulated or moved to get the needle into the plane. It is always the needle that has to be manipulated so that it should come into the plane of the ultrasound. Otherwise, you will miss and you will hit at an inadvertent spot. So if you are not able to get this, then you can, once the needle has reached near the artery, then you can turn it into the short axis view, which will help you to puncture exactly at 12 o'clock. That is seen in the farther left hand upper corner, where you can see the blue dot where the needle is slightly away from the center. Then you make it short axis and you can use it to puncture the common femoral artery. So the 6th one, again turn to long axis view, where you can see the needle, the wire entry into the lumen. So here you can see the needle right from the skin to the entry into the artery and then the wire. So these are the 6 steps. If you follow meticulously, you will be able to do a safe, good puncture in any case of common femoral artery. So this is one of our cases. So here you can very nicely see common femoral artery, profunda femoris and superficial femoral artery bifurcation and a femoral head, and the thing that is slightly above the femoral head is the scapula. But this requires a very good ultrasound machine. So coming to micropuncture kit, these are extremely useful. They come in 4 French and 5 French sizes. So it consists of a micropuncture needle, a micro wire. but the micro wire is very stiff, it is straight, it is not J-tip, so you have to be careful, and always you look at where the needle is, where the wire is exiting the needle, that is the site of entry in your artery. And also always pass the micropuncture needle wire under fluoroscopy because it can perforate small branches. And this is extremely useful because after this you can take a check injection through the microcatheter, and if you are not comfortable with your position, even now you have not given heparin, you can come out and do the procedure again. Okay. So I'll show you a small, this is a tortuous artery. So here you can see the micropuncture wire. See how tortuous. So we have passed the micropuncture catheter and we tried to take an injection, but we didn't realize that it was abutting the wall, and you can see it has caused a dissection. Fortunately, these retrograde dissections are forgiving, so we just pulled it back and the dissection didn't close the vessel. So then what we did is we passed a 3-2 wire which easily crossed, then took a long sheath and then completed the procedure. At the end we took another shoot and the artery was fine, so we left it like that. So this is one more case where it was ultrasound guided puncture, but it was a very diseased artery. We couldn't pass the catheter or wire, nothing was going beyond this point. Then we realized that there was something wrong, only few vessels are being filled up. So this was a dissection. If you can see in the left lower corner where the sheath was entering, it has caused a dissection. It is in false plane, that has caused a huge retrograde dissection extending up to the abdominal aorta. Even this case, luckily, we could manage it conservatively. It didn't involve any major vessels.
Carry on, it's okay.
So please feel free to stop at any point.
It's a very important lecture. It's okay, we'll spend some time on it.
So, so the current vascular closure device, what they are available for us are AngioSeal, ProGlide and Manta. So AngioSeal, I very briefly give you a thing. It is available in two sizes, 6 French and 8 French. 6 French is used for 7 French and below. 8 French is used for 9 French and below. As per IFUs, you can use 8 for 8 and 6 for 6, not more than that. So it basically consists of a AngioSeal device. AngioSeal device, the top one. The second one is an arteriotomy locator. The third one is the sheath, which is a 6 French or 8 French sheath. Fourth one is a guide wire. The guide wire for 6 French is 035 and for 8 French is 038. So basically it consists of a device sleeve, device cap and reference indicator, a carrier tube which houses, and a bypass tube which contains the collagen, suture as well as the foot plate. So basically it is in 3 simple steps. After the procedure, you have to pass the arteriotomy locator along with the sheath. Once it is inside the artery, then you can see a spurt of blood. At this point, you can hold the sheath with your left hand very firmly because it should not move, and you can get the arteriotomy locator outside. Then you can introduce the device, and once you have set the anchor at the arteriotomy site, then you can pull it back. And then you push the compaction tamper tube inside so that the collagen gets deposited on the outer surface of the vessel. So you have a foot plate or anchor that is abutting the anterior wall of the blood vessel, and outside it there is a collagen that is being pushed in by the tamper tube. So it is a double seal. The thing you have to be very careful is, if the anchor is not set and it is not abutting the anterior wall, then you will, suppose it has caught the posterior wall or it is not coaxial to the anterior wall, then you might be pushing the collagen into the vessel, which will immediately clot and thrombose. I will not go into the demo video, we can have the discussion outside. So there can be some disturbances in heavily calcified groins, scarred groins, high punctures. There will be anchor embolization also. I'll just show you a quick case where we had trouble. So how many of you feel that this is a good puncture and won't think that there will be any complications? Looks fairly good enough. So we thought we'll finish the angioplasty, and then this is after AngioSeal. What do you think, it is good? So one vessel is missing, right? So the superficial femoral artery has closed down. It is very deceptive because we are not used to femoral angiograms like we are used for coronary angiograms. Nobody needs to tell us what is the view, what is LAD, what is LCX. But here we are not that well off. So here the superficial femoral has completely closed off and it is not being seen in the normal routine RAO view. So we took angulated views. Here you will be seeing the stump. Now you are able to see it, I guess. So and when you took a angulated, like almost a lateral view with a cranial angulation, here you can see the superficial femoral artery stump. So this was before the image, you can see both, and after you can see only one vessel. So what actually happened is, we couldn't show the bifurcation, we were not sure whether it is above or below the bifurcation, so inadvertently we have punctured just at the bifurcation. So we deployed the angiosin in superficial femoral artery. So superficial femoral artery caliber was small, so the foot plate was stuck. It didn't come and engage the anterior wall. So we had pushed the collagen inadvertently into the lumen that caused the thrombosis. Here you can see the foot plate, which is like a boomerang, U-shaped boomerang. It has bent into a U-shaped boomerang. And you cannot see it radiographically, it is radiolucent. So surgeon has to come for our help and rescue us. So careful when you are deploying angiosin. Always and always it should be in the common femoral artery. This is a different system. It is a suture-based system. No TAVR program can or any structural program can go through without knowing this device. It is a monofilament suture. It is a. I'll just go into the deployment thing. We can discuss about the thing. So this is the only device that is used for pre-closure. So now MANTA has come, so angiosil cannot be used for pre-closure, it is only post-closure and it cannot go beyond 8 French. But this has the ability to close from 5 French to 23 French holes. You can use 2 devices. So there is a bit of troubleshooting associated with when you are using ProGlide, because what happens inside the vessel is extremely important. Outside we all see that 1, 2, 3, 4 marked. 1 is deploy foot plate, 2 is fire the needles, 3 is pull them back and cut it, 4 depress the foot plate. But what happens inside is extremely important for us. Then only we will know whether it has gone right or wrong. So this is the intravascular demo. So the device, once it is in position, from the marker port you can see blood going out. So we have deployed the foot plate. This is step 1. You have pulled it, abutting the anterior wall. Then you have fired the needles. You can see both the needles have come and caught the cuffs. The white one is called link. Then now the suture has been, the knot has been passed, the suture has been railed through the knot. Then you remove the device. So this is what actually happens. So when you pull the lever out, you have to see that 2 needles have come out with 2 cuffs and 1 link. Then only the device has fired and done well. Otherwise, if you don't see the cuffs, it is called cuff link, cuff miss. So you should understand what happens inside so that you can actually understand what is going on. So this is how it looks like. So there is a non-rail suture, there is a rail suture, and there are 2 needles. The needle already is through a preformed knot, and you have 2 links, anterior cuff, posterior cuff with a link that is white in color. Then both needles fire, then you pull back, then the cuff and link pass through the suture. This is how the knot is formed. So that is why the white non-railing suture you should never pull. It is only the other suture which you can pull. Because if you pull the white suture, it will get the knot will get tightened and you can no longer advance the knot. So we will discuss this in the evening session when we have the devices. So many times we initially used to use 2 ProGlide devices. but now we have come down using, because we are using only 14 French sheets, we are using one ProGlide at 12 o'clock, and if necessary we'll put an angioseal after that on a 6 French or 8 French sheet as necessary, because 2 ProGlides, if we are too wide, like we are taking bigger bites, it can result in stenosis like this. So the newest device is Manta device. We don't have much experience with this, but it comes in 2 sizes. So you can see that is 14 and 18 French. 14 French can close up to 18 French outer diameter, and 18 French can go up to 23 French outer diameter. So it is more like a big angioseal. So you have a 20 millimeter foot plate, and you have a resorbable collagen which is on the outer aspect of the vessel, and a sliding suture knot. But one thing is, in angioseal you will lose wire access. In this you can do it over the wire. So we will not go into the video. We will discuss about the things later. Thank you.